Good evening, everyone. Welcome to the lead extraction webinar, a webinar from our practice, and this is our seventh session today. Our goal is to present interesting cases so we can have a discussion on how to manage these patients. Today, I'm joined by two of my wonderful colleagues, Dr. Cha, who is a professor of medicine from the Mayo Clinic in Rochester, and Dr. Dinesh Kella, who is the lead extraction expert at the Mayo Clinic Jacksonville practice. Thank you both for joining today.
Thank you, Siva.
So we have a couple of cases to present, and as far as questions, please put them in the chat box, and we will try to answer them in between cases or after the cases. Thank you for presenting today, Dr. Cha.
Okay. Well, thank you, everyone. So I'm going to present the first case. Here's the learning objectives. So this case is a 34-year-old gentleman who was diagnosed ARVC based on the family history of sudden cardiac death and a mild RV enlargement elsewhere. Because of the ARVC and the family history of sudden cardiac death, he received a dual-chamber ICD in 2002 at age 15, with no ICD therapies for 20 years. And genetic testing is negative at the Mayo Clinic, and the patient wishes to remove ICD and the leads. His ICD is Medtronic Evira and attached to the Medtronic RA lead 5076 and RV Quadra Secure 6947. So this is a dual coil ICD lead.
So is that common, Dr. Cha, to see these patients after many years got these ICDs when they're kids? And are we seeing more of these as our diagnostic techniques evolve?
Yeah, it's not uncommon. And then we know the patient with genetic heart disease, family history of sudden cardiac death, long QT syndrome, for example. So, the recommendation in those times, it was strongly recommended with ICD if you have risk factors. So I think in our institution, it's really not uncommon for the younger patient who received ICD as a teenager or even younger. So come back to this case. So because the leads were 20 years old, so we performed the lead extraction in the operating room. So in general, we have a protocol, and then the patient undergo, of course, general anesthesia with the radial arterial line. And also, the patient has to have a femoral sheath to be ready. So in this case, we set up 3 femoral sheaths on the right side. And then the one femoral sheath is 9 French triple lumen for fluid resuscitation. And the one is a 12 French for the bridge balloon catheter placement. And as you can see in this case, we always inflate the bridge balloon in the SVC to make sure it's functioning well. Then we deflate the balloon and put the balloon back to IVC, but the wire remain in the SVC and ready to be reinflated if it's needed. We also set up another sheath just in case we need a workstation from below. So in this case, we open the pocket, and of course, patient has no apparent evidence of infection. So essentially, we disconnect the leads from the generator and dissect the pocket, free the lead, and relieve the sutures on the sleeves. So now we have both atrial and the ventricular lead freed from the pocket only. And then now the next thing is we put a stylet into each lead lumen, and because they both have active fixation. But despite our effort, the active fixation were not able to be retracted. As you can see, both atrial and the ventricular screw-in lead remain to be screwed. And then the decision, of course, on the table, we select the 14 French laser sheaths to extract the atrial lead first. So after the preparation of the lead with the locking starlet, and then here you can see is the laser sheath trying to advance to the SVC, but somehow we a little bit stuck at the innominative vein location. So at this situation, and as you can see, so we trying to snare from the below. So we use the EPT catheter and try to grab the atrial lead. As you can see, the atrial lead tape is already came off from the right atrial appendage. So now, after we use the EPT catheter, get the lead tape off the RA free wall, we were able to use the gooseneck snare to grab the tip of the RA lead. So in this way, we can pull the atrial lead down and then to have a force and alignment to facilitate the lead extraction from above. So, and we were able get the lead. You can see the snare already get the atrial lead straight down, but we decide not pull the lead back because this lead is already freed. The laser was able to get into the right atrium. So, but we want to keep the lead at this situation, trying to maintain the SVC and the medial sternum, so towards more medial side, which may facilitate the ventricular lead extraction. For the ventricular lead, we select the 11 French tight rail sheath, and then to extract the RV lead. And as you can see here, we did encounter some challenge when the 11 French tight rail sheath is advancing to the SVC to RA junction. And again, here, as you can see, even though we tried up, down, and as you can see, the lead tip and the lead body remain in the right atrium and the right ventricle. It's hard to see the tricuspid annulus at this point. So you can see at this point, we removed the atrial lead. And then what we noted that whenever we pull the tension on the RV lead, it resulted in severe tricuspid valve regurgitation. But if we relieve the tension, then the TR went away. So this is critical to look at the TEE. And then we will show the TEE in the next slide. So in order to determine if the TR is because we're pulling upward, or if we can improve the TR if we pull from below. So as you can see, and use the same method, we were able to use the EPT to grab the RV lead close to the coil region and use the snare, grab the EPT catheter tip. And in this way, so we can pull the lead, the RV lead downward. And at this point, even though we put downward, the TR remained to be present. And we also noted that the rotating dilator sheath is stuck. So we were unable to push forward, and we were also unable to pull the sheath back. And then this is the baseline TE. As you can see, if we don't pull the lead, there was no apparent TR. You can see this is the tricuspid valve area. And then, but if we were pulling the sheath, pulling the lead, and you can see here there was a severe tricuspid valve regurgitation. So this is just a different view. As you can see the lead is here across the tricuspid valve. It seems attached to the tricuspid valve structure. And in here, you can see in the color Doppler and seeing the TR. It's adjacent to the lead. So what's the next? So the lead has a significant attachment to the tricuspid valve, and the rotating sheath now is stuck to the lead. So what do we do at this point? And then if we really truly stuck, we tried many times trying to get the sheath to be freed from the lead, but it was not possible. So if in this situation, we could put the sheath back, so we could abandon the procedure as an option. But since we were not able to do this, and also the lead significantly attached to the tricuspid structure, so probably the surgical approach would be a very reasonable option. So we discussed with the CV surgeon and the family, and then the decision was made to undergo surgical lead removal. So this is the surgical note, and that indicate ventricular lead had a perforated anterior tricuspid leaflet and was entangled next to the papillary muscle. And the lead had calcification around it, and the combination of calcification and excessive tissue had caused the extraction device to jam. The perforation in the anterior tricuspid leaflet was repaired, and then with just one suture. So here's the intraoperative photo, and showing here, I think let's just give you some orientation here. And as you can see here, it's a tricuspid valve anterior leaflet, as the green arrow pointed out. And then here is the lead. The black color is this is the tight rail sheath. And this is a fibrotic tissue calcification around the lead perforated in the middle of the anterior tricuspid leaflet. And this is a different view, as you can see here, and here's the lead. And of course, the surgeon did the extensive dissection, removed the calcification and the fibrosis. And then the lead penetrate into the tricuspid leaflet here. And as you can see here, the green arrow here, that is the papillary muscle of the tricuspid valve attached here. So significant fibrosis, and as you can see, and here's the lead continuation here. So that's why, because when we pull the lead, it causes significant TR, because one is the lead really fibrous penetrated the tricuspid leaflet, and also it's attached to the papillary muscle, completely entangled with the papillary muscle. And then you can see this is after the lead removal, and this is the tricuspid valve leaflet, and then this is the hole, and the surgeon has to suture it up. So here's the mechanism of the CRED related to TR. As you can see, this is the subvalvular entanglement here. And then here's the leaflet perforation or laceration of the leaflet. And here is the leaflet impingement or adhesion. So with all these potential serious lead adhesion to the tricuspid valve structure, so we can imagine sometimes the lead extraction is successful. You can separate the lead fibrosis from the valve, but sometimes you may not be able to achieve the success. So from this case, the key points, 3 points here, is having a good planning and a shared decision-making before the lead extraction. And we must inform the patient about the complications and possibility of open heart surgery. When the extraction is stuck, so TE is very helpful for observing the lead and the myocardial valve interaction and the decision-making. And the elective surgical approach may have a better outcome than a successful, so-called successful lead extraction in the expenses of valve tear or papillary muscle rupture, like this case. And then this is also it's one of our cases. We did successfully remove the lead, but the consequence then was the tricuspid valve posterior leaflet entirely teared and from the valve. So patient has to go back to the operating room and undergo the elective tricuspid valve repair a few days later. So I think this is critical to make a decision during the lead extraction procedure, and then especially discussion with the imaging physicians, discussion with our CV surgeons to make the most wise decision for the patient. Thank you.
Thank you, Dr. Cha. That was an amazing case. So you showed that how you can use the directional ablation catheter to direct your snare so you can grab in one of the images on the atrial lead. So why do you think that we didn't see a lot of TR at the beginning, and only when we started pulling that we saw a lot of TR?
I think in the perforation part, it's already healed by the fibrosis, right? So if it's in the tricuspid valve relaxed situation, probably you won't see much TR in that case. And attached to the papillary muscle, and then apparently we did not see the TR. But I think if we have a lot of tension, with the lead and pulling the tricuspid valve upward or downward, I don't think that because the lead is in there, I don't think the tricuspid valve can close appropriately.
Yeah.
So I think probably that's the main mechanism. But how much that papillary muscle, entanglement with the lead, do you have much experience on that?
Yeah, no, I think papillary muscle dysfunction is another reason. It distorts the valve architecture, and then you can have TR. Especially young patients, when they have an active lifestyle, receive the devices when they're very young, they tend to have a lot of calcification and fibrosis.
Yes.
Yeah. Now, Dinesh, do you have additional thoughts on this case? Anything that you want to add?
I think it's amazing to have the surgeon come in and help out. And it's important, again, like as you stressed, about having the surgeon available for this kind of discussion.
We also have Rob Shaler on the call. He is an expert in this area. He uses a lot of intracardiac imaging. Rob, what are your thoughts? Any pointers that you want to give us?
Sure. So that was a great case, and I think it was a great example of extensive experience and mastery of lead extraction, because you got to understand what you're doing right and what you're doing wrong, what the potential implications are from continuing to go. So just great decision making all the way around. As you know, I have great respect for the tricuspid valve, and we use intracardiac echo, which is very similar to TE. It shows similar things, but I think you get a better view of the valve. And it is not infrequent that you can see the leaflet being pulled. So it's the difference between static imaging, where the lead is maybe not freely floating in the valve, but it's stuck somewhere and you don't know. Is it just sitting there, or is it stuck to something? Is it stuck to the annulus, which is okay? Is it stuck to the leaflet? You don't know. Versus dynamic imaging, which is what you were saying. The moment you start pulling, or at least the moment that you start pulling where you could exert tension on the lead at that place, which might be after you get the sheath all the way down and disrupt all of those binding sites. And then you see the valve being distorted, and you pull the leaflet with it. And at that point, you have to make a decision. And Dr. Cha was getting at this as well. Your only hope there is to use a powered sheath to dissect through that adhesion and try your best to core it out and release it in such a way that there'll be a cast left over, but the leaflet won't tear. But if that's best done if the lead is adhered to the leaflet. If the lead is through the leaflet, which you really can't tell on ice, you are going to damage that valve, and that patient's going to have severe TR. So it is not infrequent, or maybe a handful of cases where at that point in non-infected situations where we see that finding, we will simply stop. That is a little different than adhesions to the subvalvular apparatus, which are a little bit more forgiving. If you could blast through all that stuff, you're usually okay. But we've also had times where we're connected to a tiny little papillary muscle, and you know that if you exert any traction whatsoever, then you're going to have a problem. I have one thought on how to potentially get out of the situation you were in, which was harrowing, which is you don't want to continue, but you can't get your tool out of the patient's body, which is I probably would have tried to snare the lead just below where the tip of the sheath was. And I would have used a Raptor forceps to grab the lead just past the tip and then pull from below just to buffer the lead and the valve a little bit, while you can then pull a little bit harder from above. That might have given you an ability to get the sheath out, but you still would have had to deal with that lead, either leaving it or sending the patient to surgery. So beautifully presented and beautifully done.
Have you ever stuck? Ever?
I've never gotten stuck, but I think that the reason is I do not like using the tight rail for these purposes, because by its nature, it's weak. So it's prone. There are a lot of advantages to that sheath, but one of the disadvantages, it is more prone to get jammed.
So I really enjoyed your talk at the HRS about the tricuspid valve regurgitation and the lead management. That talk, that's very nice with great illustrations. So with that, so I really appreciate your point about your comments. You may manage the situation a little bit different, and maybe you can win. But in that situation, most of the time, I think we just keep extracting, we probably would achieve success, and then we can separate the adhesion and then win, right? So, and hopefully, we hope the patient has no apparent consequence requiring surgical approach. We hope that's the case.
We certainly do. We're finishing up a case series, 100-patient case series, where we're doing ice-guided extraction, which is doing exactly what I just discussed, monitoring the valve while we're taking them out and seeing how many times ice gives you actionable information that will either change what you do, which includes changing tools, or actually change the way that the procedure goes, meaning abort the procedure. And it's not infrequent that we do that. I just think that I think your chances of damaging the valve when it's as stuck as yours was is 50-50. And in a non-infected situation, I've done enough now and I've damaged enough valves now to know that you should give some serious thought to stopping right then and there if you see that leaflet pulling back. Now, in an infected situation, you got to make a clinical decision. And that's harder, and you might push it a little bit more. But in an elective case, I think you're bound to have more regret if you damage the leaflet than excitement if you get away with it.
Maybe one more question, Dr. Cha. You showed us a lot of adhesions along the lead. Do you still have the contact feel? I mean, the heart, the tactile sensation, is that still there when you do these cases? Does having all those contact points and the fibrosis dampen how you feel when you're tugging on these leads?
And then I believe many of you are doing the lead extractions. So I think you could get the feeling, right? From open the pocket that moment, you may have some anticipation. If patient has a lot of fibrosis in the pocket, you anticipate the lead might be more fibrosis. But when you go to the lead, but you do get a feeling because no matter what the sheet you select, it's hard to move forward. And and then in addition to trying to minimize the snow plowing, that is not a factor, then I think you have to go very slow. If if the infection case, we have just to go work little by little, and then hopefully we can get the lead out.
Yeah. No, I think in the extraction, it's important to know when to stop and know our limitations. In this patient, the surgeon just had to put one stitch on the leaflet versus tearing the valve and then having a bioprosthetic valve, which comes with its own problems. Thank you for presenting a great case.
Thank you.
So with that, I invite my colleague, Dr. Dinesh Kella from Mayo Clinic in Jacksonville, who will be presenting a case. Dr. Kella, thank you very much for doing this.
Thank you, Dr. Malpuru, for the opportunity. So my case is of an infected device, and the question was whether we aspirate or not. And these are my disclosures, and we will be talking about use of penumbra system for lead vegetation aspiration and other systems which are somewhat off-label. And what we are going to discuss is the role of percutaneous aspiration of vegetation in setting of infective endocarditis, particularly involving the transvenous leads. And then cannot stress enough that if you have MRSA septicemia and if you have a device, particularly with evidence of infective endocarditis, how important is it to remove it to manage infection? And so our patient, she's a 48-year-old female. She has a history of L kappa and had anterior myocardial infarction related to it. She underwent bypass surgery with Lima to LAD about 28 years ago. And now she's admitted with high-grade fever. Other important history information, she has low EF, 30 to 35%, and had an AICD implanted 20 years ago, a single chamber with dual coil ICD lead. Also has a history of pocket infection during a generator change several years ago, now has blood cultures that are growing methicillin-resistant Staph aureus. To complicate things, she had an appropriate shock for ventricular fibrillation 3 months prior to the presentation. She was started on IV vancomycin. She also had shortness of breath on presentation, so she underwent a CT pulmonary embolism protocol, CT angiogram. And on that, important findings were that there were filling defects in the branch pulmonary arteries. And there was also a filling defect noted around the tricuspid valve where the lead was crossing into the right ventricle. And with these all findings, there was concern for infective endocarditis, that these are septic emboli. And as part of our further workup, she underwent transesophageal echocardiogram. And on that, at the tricuspid valve along the lead, there was a mobile mass noted. And in presence of MRSA bacteremia, this was very concerning for vegetation, infective endocarditis. And so to summarize the case, what we have so far, 48 female with prior cardiac surgery, MRSA septicemia, tricuspid valve ICD lead vegetation, and septic emboli to the lung. And EP was consulted for removal of this CIED system, the single chamber ICD. The question is, how do we remove it? We call cardiothoracic surgery to remove the lead because of the presence of this vegetation. And we just hope and pray and just pull on the lead, take it out, how we extract things, and hope this vegetation will come with it and doesn't travel places in the body. And then the other option was to try to have one of our interventional colleagues come in and aspirate this off. And then once this is off, this mobile component, then we can remove this transvenous leads. So Dr. Malpuru, Dr. Cha, what would you do?
I think, it's good to have surgical backup, but asking them to primarily remove the lead, with the current technologies that we have, may be a bit too aggressive. You already have like a peripheral pulmonary embolus on the CT scan. If the patient is hemodynamically stable, either if you have the tools, maybe option 3. If you don't have, you could remove and see how the patient does do hemodynamically. Those are both acceptable options. What do you think, Dr. Chow?
Yeah, I agree with you. So I think the vegetation is not huge, right? In the past, sometimes we using 2.5 centimeters, 3 centimeter as a criteria to ask a surgeon and to do the open heart vegetation removal, because they could cause really a big PE. But nowadays, we do have newer technologies to facilitate or suck those vegetations or clot out, and with a less invasive approach. Probably it would be a better approach if we want to reduce the burden of bacteremia or dissemination of the vegetation.
I mean, with these kinds of vegetations, I personally always like to give cardiothoracic surgery a phone call. But as you can imagine, prior cardiac surgery, how sick the patient is, most of the time, like the morbidity associated with open heart surgery is always higher. And most of this time, like the answer from the surgeons is going to be to try something else before they will consider or not consider cardiothoracic surgery. And we did talk to the surgeons, and they felt she was high risk because of multiple comorbid conditions and then prior history of sternotomy. And as Dr. Cha said, like large vegetations, your concern when you're trying to remove it is you just wonder where this vegetation will go. And in this unfortunate patient where we removed the lead, this vegetation traveled to the pulmonary artery, to one of the main pulmonary arteries. And unfortunately, this patient died of worsening sepsis within 24 hours. And this number, 2.5 centimeters, as Dr. Cha was mentioning, comes from data that, like, if you have the size of the pulmonary artery, if you close it off completely, then you will have circulatory collapse. And this is where the morbidity is higher. And having a vegetation for extraction by itself is not an absolute contraindication, as Dr. Malpuru was alluding that, like, it is reasonable to consider removing it in smaller vegetations. But you always wonder when you have a bigger vegetation, where would it go once you start to remove the lead? And as we were discussing, Dr. Cha had mentioned about the technologies available today. A lot of this comes from embolectomy for other things, pulmonary embolism, embolectomy, or removal of clots from the circulatory systems in the brain. The main ones that we have seen in our practice is angiovac and then the penumbra system. Angiovac is the larger bore device, penumbra is slightly smaller. And the main differences between the two with the large bore percutaneous aspiration tool is that, like, you draw up a lot of blood, so you have to recirculate it. So you need 2-axis side, either VV or VA, ECMO circuit to recirculate the blood. The benefit of it is large bore, then you can suction bigger masses, and you can do it quickly. With large bore, higher suction comes the risk of suck down injury, and particularly when you're working around valves, you always risk damaging them. With small bore, such as penumbra, you can be more focal with them, but then the aspiration force is more gentle. You have to be close to the vegetation, and when you're close to the vegetation, you always worry about what if you embolize it, and then less risk of suck down injury. And because it's smaller bore, you're drawing less blood. Usually you don't recirculate, but if you keep doing it often, like, then you always worry about blood loss associated with the small bore devices. And the largest series so far reported from Europe, from Dr. Starkstrup, and what they noted with transvenous lead-associated infective endocarditis vegetation, when you aspirate them, you have decent success, 94%. Considering how sick these patients are, 3% major complication rate, and then it does help remove the leads in 99.2% of the patients, a majority of the patients. And then the risk of peripheral embolism is about 1% during the procedure. So promising, but like as far as does it really help the patient in the long term, is there any difference in mortality or subsequent outcome? It's a question because this is just a case series, not really randomized. And I don't think so with the nature of the problem that we will ever have randomized data in this regard. And if you look at the most recent infective endocarditis guidelines, where this mechanical aspiration has come for infective endocarditis in general is in setting of large vegetations to consider more than 2 centimeter. If you have smaller vegetation, but you have concern for paradoxical embolus and presence of PFO to consider it, in patient with persistent bacteremia where you have device which you cannot remove, and you can consider debulking the device, and then those with recurrent pulmonary emboli, and they are not really good candidates for removal of the device. In this patient, what we decided to use is the penumbra system, and it's a smaller French size. The benefit of using this was that we did not have to set up an ECMO circuit in a sicker patient. And what we use to make it more deflectable is this flex cat sheath, the one that's used for Medtronic cryoballoon. And with this, what our goal is to use transesophageal echo guidance and try to get this aligned in 2 views, ideally on the vegetation and suction on it. And we've done 3 or 4 runs. And eventually what we saw is that we were able to get rid of the mobile component around the tricuspid valve. Once that mobile component was gone, then we felt that it was reasonable to go ahead and extract the lead. And when you remove these vegetations, it is always surprising how big they can be. Like when you were looking at a transesophageal echo view, like it was probably just over 1 centimeter, but I mean, that's just 1 or 2 dimensions that you're looking at. And these vegetations can be sizable. And again, after removing this, you wonder, like, what if you just had removed the lead without aspirating? Like, where would this big thing have gone? I mean, we already know it has caused some embolism to the lung. And so gives you a pause to think like whether you should aspirate or not. And in most cases, we try to remove them before we remove the lead. And once this was removed, the extraction was surprisingly not that challenging. A 20-year-old dual coil lead, you always are worried that, I mean, this is one of the tough cases. Things that are in our favor was like the location of this coil, the SVC coil, it's pulled back. It's almost in the subclavian innominate vein, which gives you a good angle where to go down. That was one thing. And for most part, we were able to use the outer sheath of the laser sheath to get down and get this lead out without a lot of issues. The main part of the procedure was really the aspiration. And part of the reason why it was easy to is that this is one of the older leads made by Guidant. And most of the time with dual coil leads, you have this shock coil, which is exposed, which provides nice scaffolding for the fibrous tissue to grow around it and hold the lead really tight in the body. But one of these old Guidant leads had this core coating around it. And this core coating is the same material, a similar material that's used in waterproofing our rain jackets and other jackets. And the benefit of it is that it takes away that scaffolding, and really the fibrous tissue growth is not as profound around this. And it has been reported that these leads are easier to take out. Their extraction times are shorter. So we got lucky with this lead as well. And this is one of the leads that is actually helpful when it comes to extraction.
Dinesh, if you could go back to the previous slide where you're using just the outer sheath. Mm-hmm. Is that your common practice? Just lead with the outer sheath? I know there are many people who believe this is the way to go. Can you tell us how you decide leading with inner sheath versus outer sheath when you're using the laser tool?
So our main goal is when it comes to SVC, I try not to lase at all. I mean, if I can use something that's not powered is my ideal approach, because this is your high risk area where you risk perforation. And if you ask most of the extractionists, particularly who trained or who did extraction before any of the tools came, their feeling is that like most of this SVC perforation is related to the laser being used in this area in the SVC. And once, we ideally want to push the laser at least in the nominate vein, but like if we can't really get, I try to push the outer. And in this scenario, what really was helpful was that, as we pushed, and this is very gentle push, more pull than push, the outer sheet kept going. And since it was going well, we just kept pushing and getting the lead out. Now, had it stopped anywhere earlier, we might have switched to a rotating tool, a tight rail, usually, to help navigate this.
Very nice. Do you normally put like a venous tie at the entry site of the lead when you're doing this, or after the lead comes out?
If more than one leads, definitely. And if in this situation where we had it, like once the lead came out, we had one sheath there, so we could put a figure of 8 suture after that. Usually, if it is an extraction for infection where we won't leave anything behind, like, after holding that athebone for a little bit, I would take that out. We don't want to leave any absorbable or any foreign body back in the pocket.
So the tip of the outer sheath looks a little bit brighter. Is it what normally comes with it, or are you using a special?
No, that's a good question. This is the Visi sheath that's made separate by Philips Spectranetics, and the benefit over the sheath, the outer sheath that comes with laser, is that it has that radio opaque marker that you can see better, and then you can know a little better where the bevel is.
It is better than the regular outer sheath.
Yeah.
Yeah. Otherwise, you cannot visit. Yeah, it's not easy to be seen.
Yeah.
So, any downside if you just directly use the outer sheath? Do you worry about the mismatch to the lead because you have a big lumen there? Because I have seen some experienced lead extractors even comment that they never use the outer sheath. They always use either laser sheath or tight rail, but they don't even use the outer sheath. So people have different experience.
I think, if this Visi sheath was there before the tight rail, and that was the go-to tool before tight rail came, and then we had that option. I agree with you. Once you use the outer sheath, if this outer sheath is not moving any further, then we have to switch to a mechanical sheath or laser sheath. You would have to upsize because it's very unlikely your 14 French will go any further through this. And again, this is the same picture showing that gore coating of this extracted lead again, which comes to your benefit when removing a dual coil lead in this situation. It actually limits the fibrous tissue. And I think with this 20-year-old lead, just going with that outer sheath, part of the benefit was of just coating, in my opinion. And this is where we started. We had this mobile vegetation and the lead. And at the end, we were happy that most of that mobile component of the vegetation was gone. We still had that thickened tricuspid valve leaflet, but overall, this was an improvement from where we started. And so far, the patient has done well. And we are planning reimplant in the next couple of weeks. And the big takeaway point for me from this case and from our listeners is that this percutaneous aspiration tools is an option in this situation. It's not the option, it's an option. And if you have the right colleagues at your institution, then always run it by them. And I am lucky to have Dr. Olsabag, who claims to be the janitor of the heart, who loves to vacuum things in the heart. So he is available to me anytime for these cases. And I also want to acknowledge Dr. Vaneker's help with this case in extracting the lead. Thank you.
So there's a question asking about the bevel of the Visi sheath. Is it always pointed downwards? Can you go back to that particular slide?
So here, if you see the bevel is pointing downwards, and what you want to do is like avoid the sharp edge leading towards the free wall of the vein or the SVC. You want it to be inside. So the odds of this perforating are less.
Here again, it's the lead in the inner curvature of the lead.
Inner curvature, yeah. The inner curvature would be a good way to describe it.
Rob, any comments on how you're using the aspiration, mechanical aspiration in your practice?
Sure. First, I want to say that I thought I was listening to myself when Dinesh was describing his techniques. I mean, it brought a little tear to my eye. Everything he said was, I agree with it 100%. Some of it is style, of course, but I think he's right on. So in terms of aspiration, I think the short answer is we have no idea. The long answer is we hope that it can accomplish two things. One is avoiding very large pulmonary emboli. Now, your case was convincing that you had before that probably was bad for the patient, although the patient didn't die of a PE. The patient seemed to have died of sepsis, so I'm not sure that that pulmonary embolism was that bad for the patient. But vegetations don't tend to do that. You could see if you put up the TE image of your vegetation, you could kind of see through it. It's kind of fringy. It breaks apart. If you aspirate them out, there isn't usually too much white. Yours was a little bit bigger than I was expecting, but they usually fall apart, or they're sticky and they stick to the valve, and they usually don't go anywhere. I've never seen a symptomatic pulmonary embolism. I have sent one patient to surgery, but that patient had a chronic thrombus for years, and it was big, and it was white, and it was calcific, and that thing would have been a cannonball. So that you don't really want to mess around with. But I don't necessarily think there's a limit to a vegetation size to withhold percutaneous extraction. Now, you might want to consider doing vacuum assisted aspiration, and I would urge all EPs to do it themselves. It's very easy. We are better at moving around in three-dimensional space than interventional cardiologists, and ICE guidance is beautiful, and it's so easy to find out exactly where you want to go. We tend to use Inari because it's bigger. Penumbra is just not big enough, even though it's very nice to have that deflectable sheath. But would you do it here? This one's too small, I think, or at least I wouldn't have known how big it was. But when they're quite big, you say, well, can I accomplish my second goal, which is decreasing the rate of death at 1 year, which is still sitting around 20-25%. And is it because you're not debulking them? Well, we hope so. I think it's ripe for randomization. It would be perfect case to randomize, right? Aspiration or no. You just need millions of dollars to run that trial, and it would probably require a large number of patients. So when they're big, when they're 3 centimeters, 4 centimeters, really serpiginous and ugly, and they're in a good position, we don't hesitate to aspirate them out. But yeah, you get some goes probably to the lungs because of what you're doing. You don't know if you're helping. We hope you are. And billing is an issue too. You can't really bill for these. So some people do, some people don't, but it's a controversial issue. So it's evolving, I would say.
So some of these tools are non-directional, right? Dinesh and Rob, do you have any tips on how you get these sheets to the area that you want? So for example, you take an angiovac, it's just a straight funnel.
Oh, they both of the penumbra, you do what Dinesh did. You put it in a deflectable sheath, but it's too small. It's only a 12. The other ones do have deflection mechanisms. They're just not active. So they come in J's, and then you put an outer sheath over it. And then if you push the outer sheath over the J, it straightens it out. And then once you get it into the heart, you take the outer sheath back, and it makes its J curve again. So you can usually reach the tricuspid valve in most cases. It's very hard to get into the ventricle, but on the other hand, vegetations don't really exist in the ventricle.
And sometimes, you can use these treats through the IJ, which also helps in, difficult cases to direct where you want to go.
Good point.
Yeah, I think this is an evolving field. And Rob, as you said, this area is ripe for, some clinical trial, because we don't really know after spending all this money if we are really impacting patients' morbidity or mortality. Thoughts, Young May?
Yeah, I agree. So to the point, what's the indication we should use the, invasive, this type of approach, proactively to really remove the clot of vegetation rather than just do the lead extraction. And as Rob mentioned, how many times after we do the lead extraction, no matter how much fibrosis or even vegetations, how often do we really see a big PE, right? Yeah. We rarely see a patient has symptomatic PE after the lead extraction. I believe I think a majority has subclinical PE. And then, but we just did not study. We don't know. So, but in any rate, so I think that is but it's a worth a study. So far, we have not studied the patient really did not have morbidity of the PE issue from a clinical standpoint. But another thing is, it's the timing, the time and the cost, and then the blood loss. You're doing these procedures. So it's a lot of factors. I think we have to, based on the individual patient, and then to have a good thought through to make the right decision. But definitely, like you said, evolving field. I think we will gain more experience and see those more publications. Probably will educate ourselves.
Dinesh, when you have such PE, most of them are infected material, right? In your practice, do you ever see them progress to like an abscess in the lungs?
Not that I have personally seen. I mean, the only experience that I had with the embolism was like patient dying of worsening sepsis. But you have to also consider, that patient, some of these patients when they die, you think back, they were pretty sick to begin with. Then you're blaming the pulmonary embolism or blaming you extracted or aspirating. Again, as we discussed, all questions. Lung abscess with MRSA, I've personally not seen with this. I feel like with MRSA, most of these patients are very sick if they are progressing to lung abscess kind of a situation. And they die before that.
So one question from the audience is clarification regarding billing. So, sometimes we are behind the scenes and we don't know all the reimbursement details. Is it true that we cannot bill for the debulking of the aspiration of these vegetations?
I believe you can bill for embolectomy, but again, as you said, we're behind the scenes, not necessarily knowing about the reimbursement.
We've gone through the process because these are very expensive. Even though they're sheaths that just aspirate with a syringe, they're like $10,000. And you can use codes like thrombus in transit and things like that. But it turns out that the spirit of these codes are really for embolectomies in the lungs where they can bill. So you can talk to the company billing experts, and then you have to talk to your administrators and see if they're comfortable doing it. Our administrators were not, and we use a special type of code. I can't remember the specific name for it, but it's a code that is used to gather more information about how often that code is going to be used for CMS to then make a decision whether it will provide a formal code that you could bill for. So, which is not that rewarding for the patient. So for these procedures, if we use a sheath, that's $10,000 that the hospital is giving us because we think it might be helpful, and we're committed to gathering our data and reporting it and contributing to the scientific effort.
Great. Thank you, Rob, for those comments, and always great to have you on this conference. Thank you for joining us today. Thank you, Dr. Cha and Dr. Kella, for presenting these amazing cases. And many of these recordings are available online after the webinar. Okay. Thank you, everyone.